Yeah, thanks. Thank you very much for inviting me. I'm here to talk about shaping a healthier future, or as we locals know it, shaping a wealthier future, because that's what McKinsey seem to have managed to do through it. It's, as Gurj talked about, a huge scheme across North and West London involving a massive cuts programme to acute services, 4 out of 9 A&Es, the demolition of main buildings at Charing Cross and Ealing, the closure of Ealing Maternity, the loss of many, many acute services and hundreds of acute beds. It's difficult to be specific about how many because they changed the goalposts so much, but at least 300 at Charing Cross Hospital. And I suppose I want to say, well, why does it matter to people in South London? Because you've got your own problems. Do you know what I mean? I mean, what does it matter? It matters partly because our NHS is interdependent, and cutting out services in one place means that the burden goes somewhere else, so that there's a knock-on effect, which we all know. It also matters, I think, because of the scale of these cuts. This is the biggest cuts and closure programme ever planned within the NHS. It affects at least 2 million people, a population bigger than Leeds without A&Es nearby. So that's why it's important. I think it's also important because in North and West London, the McKinsey template has been very well developed. And so it's a template they intend to use and are trying to use everywhere else. What people said in Leicester, it just sounded very, very familiar again. I'll move a bit. So it matters because what they try to do to us today, they will do to you tomorrow. And in a way, if there is a template that they are using, we'd like to use the template too. We'd really like to use the Lewisham template, where actually you manage a successful, massive, broad-based campaign and actually manage to stop some of these closures. And we would really like to be the new Lewisham, or the Northwest Lewisham at the moment. We're really asking you for your support in that way. They rationalise the closures by saying that things can be done out of hospital and that community primary care will cope with many things that are currently being done in hospital. And I think I want to just explore that. I have to talk, I'm not going to give you detailed statistics because I don't think that's useful to you. If anybody wants to know more, Michael Mansfield has just produced an absolutely brilliant final report from the Health Commission we set up, which gives an awful lot more detail about exactly what's going on, and if people want the links for that and so on, I can give them at the end. But I definitely recommend that. I suppose the first thing to say is often community care can be better for patients. You know, if people can stay out of hospital, it's often more comfortable, it's more convenient, and it's often safer in terms of reducing hospital-acquired infection, pressure ulcers, risks of immobility, etc., etc. That's very true, and actually as a community matron and district nurse, I've spent an awful lot of my professional life trying to keep people out of hospital. But it's not the best thing for everybody, and it needs to be well-resourced and adequately run. Nor is it a new concept. If it was easy, we'd have already done it by now because we've been trying for a good 20 years. In fact, still we're in a situation in which whilst 90% of NHS consultations happen in primary care or community care, that section only gets around 8% of the budget. Our concerns with the move out of hospital care at the moment is it would be acceptable if it was evidence-based, if it was adequately resourced, and if it acknowledged that there were many groups and conditions that it would be inappropriate to care for in that way. I think resources are absolutely critical because, as one of the other speakers said, community care does not come cheap. It's not the cheap option that some people seem to think it is. And I think as well as the problem of cost, there's a particular problem at the moment that as well as trying to do this massive reconfiguration, there's a whole institutional meltdown going on where the services are becoming extremely fragmented, trusts are competing against each other, and the whole approach, therefore, of trying to push forward with community care, which absolutely would have to be integrated to work, is extremely piecemeal and often exactly the opposite of collaborative, because trusts are competing with each other for business, and some bits are being cherry-picked out to the private sector. So it's a patchwork approach which really, really is undermining to the concept. Let's start. I share the concern some people have about, with health campaigns, it's always difficult, because if you point out a shortfall, you don't want to diss the NHS. I believe in the NHS, but so there's always that dilemma. So I want to start with a couple of examples that I think are plain really very good. So, for example, there is I'll just do one because I'm short of time. There's an initiative called Coordinate My Care, which is designed to put online people's wishes about what they want to happen at the end of life. Which means that, theoretically, whether you're the GP, the consultant, the paramedic, whoever, you know what this point person wanted, where they want to be, who their next of kin is, etc., etc. Now, that seems to me the kind of thing that is just straightforward, a good idea, end of. Oh, that they were all like that. I want to look at one that I think is a bit more problematic, and it's something that can be dressed up in so many ways. It's currently called the Community Independent Service. I think before that it was a virtual ward, before that it was a hospital at home. But it's basically trying to do intensive nursing and medical work at home to stop people going into hospital. Absolutely nothing wrong with that. It's got high caliber staff, it's got excellent funding, but what's the problem? The problem is it's short term. It doesn't really, it's designed for around 8 to 10 weeks. The high caliber staff don't grow on trees. They come from the bread and butter services that have been diminished to fund this. And the funding is prime pumping. It's brilliant now. It's under the Better Care Fund. But is it long-term sustainable? So the issue is, and at the moment, actually, the stats on them, they're very marginal, but they're good stats. They are reducing hospital admissions to some extent. That's fine. The problem is, it's robbing Peter to pay Paul. They've invested a lot in that, and actually the bread and butter community nursing and primary care services have suffered as a result. And so you're sorting out one problem by creating another somewhere else. And actually, to be really brutal, I think there's a lot invested in this project because it's a loss leader. Because if they can prove that this is useful and justify it to cut acute beds, they will do. I don't necessarily think the funding will follow long term after that. And I think there are consequences of the bread and butter services being diminished. I could give lots of examples, but I wanted to look specifically at cancer. And what I'm talking about is not just a local North and West London problem. It's a problem across London, across England, worse in London, and perhaps a bit worse where we are, about poor cancer detection rates. First of all, low screening rates, right? Lots of low, poor public health screening rates, and relatively low rates of diagnosis in primary and community care. So across England, I think something like 20-25% of cancers are diagnosed in A&E, which is clearly very poor, and actually the people that are diagnosed there have very, very, very poor outcomes. So I'm just trying really to give a picture of what we would need to get right before we could agree to more care in the community. We need to fund our primary and community care services better. We need to address the terrible vacancy rates for district nurses, the awful rates for GP services. We need to have a London ambulance service that wasn't in special measures. We need to be sure that if there were problems at home, people could see consultants quickly, that there would be good reviews. Instead, we have very high rates of cancelled operations and cancelled planned admissions. So that's on the health point of view. In the social service point of view, which is the other element of that, it's an absolutely disastrous situation where people will absolutely know that social care funding has plummeted and is going down. And in fact, the leader of Ealing Council is quoted in here as talking about a graph of doom. which means the difference between the need going up and the funding going down, and that bit in the middle is part of the graph of doom. A bit colourful language for an Indian councillor. But so you have the problem with health, you have the problem with social services, and in that, actually, not only that, you also have big macro changes going on that might make all the good little projects we can do a bit irrelevant, because there is a trend towards more acute admissions to hospital with much more complex needs, often requiring longer time. And that can be for things absolutely out with the NHS control. There's a population boom going, particularly in London. There's a huge increase in housing need and also rough sleeping, 16% in London last year. That clearly has ill health implications. Rough sleepers are much more likely to go to hospital. Over 9,000 people died because of air pollution in London last year. If that's getting worse, then that has implications for acute admissions. I could go on, but my point is there are big forces at work that really have to be taken into account if we're genuinely going to have an integrated plan for London. And we are nowhere near this at the moment with the sort of stuff we've got at the moment. I would just finish really on looking at one specific group, because they're a group that there's a lot of focus on. They are seen as a burden because they go to hospital a lot, and that's probably the frail elderly people. Now, I think that the idea that there are specific measures for them could be useful, but the way it's being played out is often actually at the moment pretty ageist and pretty discriminatory. Because actually, if I'm 78 and have a cardiac arrhythmia, I don't want to be put necessarily in a frail elderly unit. I want to see my cardiologist, and I want to get, I want to have my ablation or whatever I need, and I want it all there now. I don't want to be put somewhere else. So I think there are issues around that are potentially worrying. I think it's particularly worrying because there are financial incentives for acute trusts not to admit too many. There are financial disincentives. They get penalised. Community trusts get financially given rewards if they reduce admissions, and I think it's a very toxic mix when those sort of combinations combine. What I really worry about is that we will be left, if these changes go through, with a lot of people who are cared for at home. But as the other lady said, we won't know if that care is adequate or not. If it's suboptimal, and if you look at social care, and if that's the model we're following, then it's likely to be so. If people become iller, if their heart failure is less well managed, if they die a bit earlier, nobody will necessarily notice. And it could potentially be, and why I'm engaged with this is because I feel it could be the next huge health scandal of our time. So I want to finish by saying that to me, I know I've painted it very broad brush, I can give lots more detailed statistics, but it seems to me really important we talk about what we can do to challenge this. I think people have talked about united campaigns. There definitely has to be a kind of pan-London approach. I think we and you should look at and use the Mansfield report. I think we need to look at the fact that we have got a shadow cabinet who actually all of them have signed up individually challenging the Shaping a Healthier Future programme. I would really like to get a shadow cabinet position now with Jeremy Corbyn, John McDonnell, Heidi Alexander saying no to this. I'd like some help in arranging that if anyone knows how to do it. And I think we have to kind of promulgate the stats. It's clear from today that we know that we've got an absolute wealth of evidence, that the evidence does not stack up for making massive acute closures. We need to put that forward, really raise public awareness about it, but then channel it into something that's going to make a difference. And I think a pan-London campaign, I think we should be looking at the mayor elections, because that is something where people will be vulnerable, and we really need to make it as high profile as possible. Thank you very much.
Just to summarise, I hope that we have given you quite a detailed analysis and some of the arguments and issues across a whole range of questions. The reason there's been so much ground to cover is because the attacks are coming from all fronts, from all directions. But at the same time, I hope we've brought together campaigners across the board who've shown with great depth and insight some of the very hard work that's already been done, and I hope that's been inspiring. I think one of the messages is that, as Tony said, it is hard work, it's painstaking work, and there is a very important role for scrutinising, for questioning, for going along to these meetings that they hold, the Health and Wellbeing, the Scrutiny Committee, and challenging. We actually have to be the health watch, the real health watch, the people's health watch, because we are there to we have to be there to scrutinise and demand and ask questions and demand transparency. But more than that, we also have to get out on the street and just talk to people, and we have to translate everything into language that people can understand, and that is vitally important. I hope that people will carry on in their own local groups, carry on with this work that we've been doing together, liaising, and maybe there'll be other conferences, there might be other work being done across London. I think Anne was talking about perhaps a London event, getting together across London. We're going to have a conference, the Health Campaigns Together organisation that Tony mentioned is having a conference on Saturday 30th of January. This is going to be a big campaigning conference, which I think will focus on some of the things we didn't have a chance to talk about today, which is how do we take the movement forward. So we will definitely be publicising that to everybody who's here and beyond within Lewisham. I'm going to call the day to an end now. I first of all want to just very much thank all our speakers. They have been fantastic. So, round of applause.